treat the patients, but there are situations where we may suspect something else going on, so we can repeat and confirm, and then any borderline type TSH reports you may want to confirm. When do you give a trial with thyroxine in this subclinical people? When the symptoms are so much and the patient is miserable. This trial is explained to the patient that we will give you thyroxine for a few months or a year, and then we will see what is to be done regarding the same thing. Pregnancy always treat. This is the curve with you get with which you get sick thyroid syndrome, and that comes into differential diagnosis of secondary hypothyroidism. Pictures are similar. Thyrotoxicosis we should do high. We know what it is. What I'm going to talk about is what further tests do you need. Most of the time we don't need any further testing and we can start treatment. TFT in pregnancy, TBG increases, HCG stimulates, and net result is T3, T4 is elevated, and you can have FT3, FT4 to do, which may also be mildly elevated. In 5% of patients, TSH can remain suppressed throughout pregnancy. Any TSH more than 4 is recommended to be treated during pregnancy. This is just a saying by Socrates, the wisdom lies in one's confession about the limits of one's knowledge, and as you grow older, you will be more aware of what I am talking about. A female 30 years delivered 3 months late, as most of the people know what it is. This is a thyroiditis. Why do you say thyroiditis? Because TSH and T3 and T4 are not very much elevated. This is the difference between, most important difference is rapid onset. Fever, which is usually not present in Graves, which is very feverishness may be complained but never fever. Relation to pregnancy almost always specifies that it could be postpartum thyroiditis. TRAB is usually negative. It is positive in Graves, but it's not recommended as a routine test because it's very costly. Improvement of thyroiditis without any treatment, whereas the other one worsens. This is the scan of thyroiditis. Please remember that it should be contraindicated in PPT. Other types of thyroiditis we would see. And there's a clinical course of postpartum or sporadic thyroiditis where you have a serum T4 elevated initially, and then you have when you have this thing of hyperthyroidism followed by euthyroidism, and then you may go into hypothyroidism. Everybody doesn't get all these 3 features. Many of them stop at euthyroidism, but even if they get hypothyroidism, within a year or so, they would come back to normal and you may not need any. It's a self-limiting disease. The most important message I want to say is no steroids, they don't work. 30-year-old female with abnormal TFT, no, we will not go into this. This is a secondary hypothyroidism. Most important thing is pregnancy with Sheehan syndrome. LYH, if no bleeding, they typically come with lack of lactation. What test to be done? Serum cortisol in this case. There are another situation where you can get a secondary hypothyroidism where TSH is mildly elevated, and that also needs to be considered. We need to confirm panhypopituitarism. Steroid replacement has to be first. If you first replace thyroxine, patient metabolic rate increases, and that creates problem for the patient. When do you do nuclear scan? Thyroiditis. SGN when TSH is suppressed. If the TSH is normal, you don't go for a scan, it doesn't give you any function. You do it for if TSH is suppressed, you want to rule out autonomously functioning thyroid nodule. Different types of thyroiditis, thyrotoxicosis we want to separate. And if you are planning radioactive iodine therapy, an elderly lady comes with 45-50, I may plan radioactive. So I may do STC scan for later treatment with radioactive iodine. When we should not do pregnancy and breastfeeding, all of you know that. When do you do USG for SGN and MNG without toxicosis, normal TSH, normal thyroid function? Number of size of the nodules are measured by thyroids. Presence of halo and certain other things are less likely to be malignant. And if they are benign, we repeat it after 1 year, normally followed for 3 years, after which we don't follow them. And when FNAC is indicated, all SGNs more than 1 centimeter or thyroid score more than 2. They are wider than tall nodules, mixed homogeneity and male onset, or patient is on thyroxine, complains of a last 2 to 3 months thyroid enlargement, beware, it can be malignancy. You must do a FNAC. When do you monitor? Very often all T3, T4, TSH is done. So primary hypothyroidism, 90% can be sorted out only by TSH. In secondary hypothyroidism, only FT4 is done, TSH gets suppressed on treatment. In hyperthyroidism, FT3, FT4, TSH in the initial stage is not necessary, but after a year of treatment, you start doing TSH to find out whether TSH comes back to normal. When you have a sick euthyroid syndrome and you suspect that, 6 to 9 weeks after complete recovery, you will get a normal thyroid function test. There are other things, amiodarone, pituitary surgery, irradiation of breast cancer or neck structures which can give you, and monoclonal antibody therapy. What do I do? Just, I don't know which is the number of the slide. What do you do when test results are incongruent? When test results are incongruent, you would look at first the clinical symptoms and signs and decide whether it requires any further testing. I have seen patients with 20 years going on with repeated vomiting and low BP, getting admitted, take IV fluids, go back home normal, because adrenal insufficiency can be corrected by normal saline and other things. But these repeated episodes continue. That's when the thyroid function test would be very useful, and the serum cortisol which could be done. If it is suggestive of mild thyrotoxicosis and the TSH is elevated, look for lab error. Clinical features does help here, and further tests may be required because abnormal TSH is rare, but it is described. On treatment with carbimazole, this is practical where we get these things. T3 is elevated, T4 is elevated, and TSH is 0.2, suggestive of it is not completely come out of it. This patient is well and has put on weight. That means this patient has lot of antibodies against T3 and T4, and these are interreacting, giving you a high reading. You do not do anything to the patient, just follow up. Patient should be okay. Routine testing in a male patient showed that serum T3 was 180, T4 was very high, 17, and TSH was 3, which was suggestive of a normal thyroid function. On history, the patient said that his sister had similar picture. She would be treated for Graves' disease. She would be labeled like Graves' disease, give for 1 month when TSH goes all high, and then they would stop. Again, this would keep on happening because they did not understand this. This is a classical case of FTH, familial dysalbuminemic hypothyroidism. Positive family history is important, and in this patient I got them to do the ladies and the daughters. The daughter also had similar picture. I would end the slide by saying that the illiterate of the future are not those who can't read or write, but those who cannot learn, unlearn and relearn. This is very important. We have been doing it for the last 10 to 15 years. We should be always ready to revise our learning.